up to knee region, your homework. Today knee I will not explain, I will make the cross sections with you. For femoral region, upper, middle, lower thigh. If I don't mistake, last time we finished to speak about sublingual. Totally.
Yes.
It's anterior femoral, posterior femoral region. Try to read also, that is not hard. Try to read also the knee region also. If you will have questions, I will explain it for you next time in our lecture. Okay?
Only
Ashwin
is absent. Roll number 6. Roll number 6.
Number 6. As one.
Yeah.
Do you have any questions? If not, let's start. Guys. Let's remember together what I said you last time, that extremity has specific arterial supplement between each, which is different extremity from all another regions, which is make, by the way, much more complicated surgical treatment here, because majority of the traumas gives profuse bleeding, and if the main vessels and nerves is damaged, this is, guys, can give the life-saving problems, emergency situations. I want to say, I spoke about it, but just let's remember, guys, today if the killer want to kill somebody, it doesn't damage the heart, damage the femoral artery. You know why? If your heart is located approximately 15 centimeters deeper from the chest, your femoral artery located approximately 2 centimeters deeper to the skin. And if below inguinal ligament, femoral artery will be cut. Time to kill the person equal up to 4 or 5 minutes. During 4 minutes, the bleeding, profuse bleeding, so you understand, diameter of this artery will be equal to my finger diameter. So, very short time will be necessary to give the critical loss of the blood with formation of all pathological problems, which is finally will give the mortal complication. Let's say, from that point of view, friends, to be very serious, then you will see traumas of the extremity, especially open fractures. Because in case of the open fractures, you understand that the fragments of the bone perforated soft tissues, and during this perforation, they can damage everything, they can cut everything. Before I will start to draw for you the region, let's remember the borders of it, yeah? From upwards, you know, borders is not symmetrical. Upper, anterior, and upper posterior borders located in different levels. Upper anterior, it is your inguinal fold or inguinal ligament, call how you want. Posteriorly, it is gluteal. If you will compare the position, you will see that gluteal fold near the 10 centimeter located down to the inguinal fold. Conclusion: anterior femoral region is bigger than posterior. Inferior borders is absolutely equal because you know circular line. You palpated your patella, you provided circular line, and from that region, as you remember, yeah, anterior and posterior compartments of extremity will be equal to each other. And finally, you must provide it two imaginary lines. Upwards laterally, it is anterior superior spine, the lateral epicondyl. From medial side, exactly from symphysis to the medial epicondyl. By these two lines, anteriorly we have anterior region, posteriorly we have posterior region. I think it's not a problem. Okay. And one more problem, guys. One more specificity. Last time we discussed together which gates connected our pelvis with the lower extremity. Which gates provided vessels and nerves from pelvis? Because all these vessels and nerves come from pelvis. Now let's remember, we have such kind of the gates anteriorly and posteriorly. anterior biggest communication. We discussed this last time, and we call it subinguinal space. Through this subinguinal space, the main artery and the main vein, together with the bigger one of the biggest nerves, not the biggest one, because biggest will be in the backside. It is
Ischiatic nerve.
But it is also very big, nervus femoralis come to down. By the way, remember please how we projected femoral artery. This is critically important. You take imaginary line which is connected midpoint of your inguinal ligament with the medial epicondyle, but strongly your extremity should be in special position. Half flexion in hip and in knee joint, and external rotation of extremity. If you will not give this position for extremity, the line will not mention the passage of the artery. Again, you make 90-degree angle for both these joints, and you make external rotation. If now I will connect the two mentioned points, this line we call the projectional line of the artery. Very important landmark for us to make access. The understanding, by the way, by the author, we call the line of Kahn. Remember, Kahn's line. But if I will just connect it two mentioned points in the normal anatomical position of extremity, it will be projection of vena saphena magna. You see, same projectional line, different position of the extremity, and we achieve the projection of two different structures. Say, gate number one, we understand. Gate number two, it is foramen obturator. Again, it makes communication with anterior femoral region. Remember, please, if you want, you can take the pelvis. In my room, we have the model. But I think you imagine, obturator aperture, which is between superior and inferior branches of the pubic bone. Exactly in the superior medial margin, the obturator membrane split it into two layers. And between these two layers, the channel is formed. Channel is passed from laterally to the medial, from up to down. Through this channel, obturator vessels, which is from the branches of, they come from the internal iliac artery, and the obturator nerve, which is come from the femoral plexus, descending to down, come to our thigh region. And after you will see they enter inside of the medial osteofacial compartment. Otherwise we call it adductor compartment. And medial supplement forms the anastomosis, medial supplement we will mention in the future. So anteriorly we have two communications. One, it is subinguinal space. Second, it is nothing more, guys. You don't have anteriorly any another connection. In the backside, you have three connections. You know very well. Suprapiriformis aperture, infrapiriformis aperture, and alcock channel. Alcock channel exactly doesn't forms the communication with lower extremity because it goes into the perineal region. But portionally, of course, it is the gluteal compartment. That's why we mention it also. Suprapiriformis, infrapiriformis. You can say, sir, these vessels doesn't reach the free. They reach. For example, they come to the region of the trochanter-Meyer, inferior gluteal branches, and make here the trochanteric network. Or they give the medial branches in the level of the pubic symphysis, again, medial surface. Here also they make the collateral network. It doesn't pass longly in the lower extremity, but some branches they give to the lower extremity and make the supply. But anyhow, guys, you must remember that the lower extremity, like an upper one, has, let's say, tubular shape, supplementary specificity. From one point up to last point, we have one big tube. And along of this passage, it will give the several branches, to medial side, lateral side, upwards, downwards, and will supply everything. And you will see that in several levels, in the level of our hip joint, in the level of our knee joint, in the level of our crurotalum joint, we have formation of the collateral arterial network. So we will see several collateral networks. How much they will compensate it problem, another situation. Usually it will be not complete compensation. Usually not complete. For example, in upper extremity, you remember, we have complete compensation due to work of the cubital collateral network. And keep it in your mind, here we have 4 descending vessels. Unfortunately, in huge knee region, which is thrice bigger than the cubital region, only 2 descending vessels. All another vessels will be or horizontal or ascending. But the most important for us is descending artery because it is delivered arterial blood. And others just take it. Do you understand me or not? Because you understand that arterial blood here pass from up to down and vice versa. Do you understand it or not? Let's start to make the picture. Write the name of the first cross section, upper third of the thigh region. As I will choose, for example, right extremity, this will be medial side, that will be the lateral side. And let's draw the scheme. On my picture, that is the structure 1. And a little bit about scheme, guys. Now, minute attention. The more medially you come and more upwards, the more thin, elastic and movable skin you will see. The more down you will go, or laterally, or backside, the more thickness of the skin will be enlarged. By the way, the thickest skin here we have in the lateral posterior surface. So remember, please, medial superior region, it is thin, elastic, movable. Laterally and posteriorly, it is turned into the thick and not so much elastic, not so much movable. By the way, it is explained by the amount of the septus, which is from superficial fascia, come to the skin and fuse with the skin and make it fixation and at the same time make the thickening of it. Remember, please, in medial upper region, no any septus. And that is meaning why here we can have the big, we say, flower shape, or we say flapiform wounds in the case of the traumatization. Because skin is easily disconnected from deep layers because it doesn't have junction. In the lateral, in the posterior parts, situation another, skin is firmly connected with superficial tissue. That's why it cannot be so easily separated from the deep layers. If you will make, for example, I don't know, experimentally, same power trauma in the medial and in the lateral, you'll see that medially wounds is formed much more easier and size of the wound is much more bigger because of loose connection between superficial and between deep structures. Okay?
Yes.
More of these, guys. The more up and medially you will come, the more sweat and sebaceous glands you will see, and of course hairs. Especially near the inguinal fold, especially in the medial part near the perineum. And that will make possible all inflammations, which we studied before together. Let's continue now. We will go deep. And next, my ring. This is time to change markers. I will draw the next structure. Structure 3. As always, we draw propagation because between 1 and 3 will be in layer 2, yes? Subcutaneous fat tissue. Put immediately number 2 also. Let's say 2 will be fat, 3 will be proper fission. Don't forget that this number 3 is double layer. Immediately now you see superficial layer. Superficial layer just cover all our surface of extremity. By the way, don't forget that in the lateral side, it stands very thick. And put here number 4. Don't forget that this is tractus iliotibialis. Tractus iliotibialis. I don't know, is it good visible here or no? For example, here you can try to see,
Yes.
that it's become to non-transparent, very thick. Why so thick? Because you know two tendons fuse the proper fission. From upwards it is the major gluteus, and from downwards it is the tensor fasciculus. Let's say it becomes very thick, like aponeuros.
Yes.
Like aponeuros. You can say me, there is the deep layer, guys. To show here deep layer, first of all, I must draw bone. I must draw the bone in mid-side of our picture. In reality, it is triangular shape, by the way, you know, yeah? Linea aspera, labium medialis, labium lateralis, but I draw it by the round, just structure, no any different structure 5. And now we are able to draw deep layer, because deep layer will pass between muscles, deep layer of the proper fission. It will pass between muscles, and finally will come to the bone and will fuse with the bone. Yeah? That's it. Let's draw these septors. One in the medial side, up to the medial lip of the linea aspera. Second, into the lateral side. And the last one in the back, but you see that it doesn't join the bone. It is finished inside of the muscles. So I put here letters A, B, C. Call please A medial septum. We call intermuscular septum. B lateral intermuscular septum. C posterior. And in each one, its own interfacial space. Inside of A medial interfacial space, inside of B lateral interfacial space, and inside of C posterior interfacial space. You see, guys, the difference between the structures of the arm and femoral region. In arm, we have only 2 interfacial spaces.
Yes.
Here we have
3.
And also you can recognize in this picture 3 osteofacial compartments.
Yes.
Number 1, number 2, and number 3. Again, right to not forget, 1 we call anterior or extensors, 2nd we call medial or adductors, and 3rd one we call posterior or flexors. Say the name according to position and according to function of the muscles, yeah, which is inside of the spine. Now we need attention to me, guys. Then you meet the imaginary division of the femoral region into anterior and posterior. From the mentioned spaces A, B together with 1, 2 included in your anterior thigh region, 3 together with the C included in posterior thigh region. So that is of course imaginary division, but to make much more easy your studying, you have to make a classification. But remember for you yourself, yeah? First and second with A, B, we include it in anterior thigh region, 3 together with the C, we include
posterior
it in
thigh region.
I think it's not happening.
Yes.
Okay, now a little bit about these spaces. Last time in my lecture I told you that interfacial space contains neurovascular venules.
Yes.
Interfacial space is empty space with loose connective tissue and tubular vessels and nerves. That's why inflammational process can be very widely spread inside of the space. More of this. Space become to very superficial. As you can see, it is reached up to the level of subcutaneous fatty tissue, and only superficial layer of the proper tissue divided it from the subcutaneous. That's a local signs of inflammations will be very visible. Yeah, redness. I don't know inflammational signs, anything else. Vice versa, if the problem will be localizated in osteofacial compartments, which doesn't have empty place because they completely occupied by the muscles. Usually you will not see the problem because problem will be deep. But vice versa, we will see much more better the general signs. Because as you understand, muscles has huge supply, they will absorb the toxins, which is originated due to any inflammational process. And instead of the local signs, we will see the general sign, intoxication, let's call it that way. Is it understandable? Now look please to me, in the right please, space A in upper third of the femoral region, because our picture is upper third, yeah? We call that femoral triangle. And it contains the main neurovascular member. Space A in upper third, we call femoral triangle. By the way, for yourself, you can write in mid-third, we call it anterior femoral groove. In middle third, it will be called anterior femoral groove. And in lower third, we call it adductors or hunters or femoral popliteal channel. 3 names. Adductors channel, hunters channel, or femoral popliteal. And totally inside of this space, from up to down, we will have main neurovascular bundle. Minute attention. About this neurovascular bundle last time, its origin, everything. I give you all necessary information. Femoral artery, which is continuation of external iliac, femoral vein, which is not drain, continues into external iliac, and nervus femoralis from the lumbar plexus. From subinguinal space, they traverse to downwards, they come to the femoral region. And you can see this big triangle guys. I showed it last time. Again, let's use our imagination. This is in our picture, which is the cross-sectional picture. If I will transfer into the frontal picture, it will become to such kind of a triangle. Now, if my hands, you will cut it in cross direction, it will have the form of this.
Yes.
If you look from frontal side, you see triangle. Is it understandable? Now, what is borders of this triangle? What is form this triangle? Before to speak about borders, what it forms? Of course, deep layer of the proper fission. Otherwise, it is intermuscular septa. It is septa A. These are my hands now. Look to me. My hands. It is these double layers of intermuscular septa. How much they goes to deep? Up to bone. Up to bone. Of course, this septa will be between muscles. That's why we call it intermuscular. And from one side, you see it border anterior osteofacial compartment. From another side, it border the medial compartment. That's why look to upwards. It will touch of the extensor muscles, which is located in compartment A. To downwards, mainly, it will touch the adductor muscles, which is located in C. So keep it in your mind. Remember, again, this is triangle. My right hand touch to my extensors. My left hand touch to my adductor. So it's not hard to imagine. Immediately two muscles. Now let's imagine, as I show you in the lecture, remember, imagine that behind of my hands, now we have two other hands. Behind of my right hand will be iliopsoas. Behind of my left hand will be pectineus muscle. Because this is medial side, that is lateral side.
Yes.
Is it understandable
Yes.
for you? So remember, please, floor of our triangle forms by these two muscles. By iliopsoas, by the pectineus muscle. What is the roof of my triangle? That is roof. And what we good if you will perform. Draw, please, aperture immediately this roof. What is this roof? I think you know. Yeah, it's superficial layer of the proper tissue called fascia. Fascia lata. And immediately part of this fascia lata, which is covered our femoral triangle, here it's removed. But if I will open your previous picture, you will see this fascia lata. And you see the portion of it which is covering your triangle. Here is your triangle. And you can see that it's perforated. Last time we discussed together that this aperture we call hiatus saphenous. And that is superficial ring of your femoral channel. We draw it. So you can put here the number 6, and you can call it, of course, it is hiatus saphenous. Or superficial ring of femoral channel. Call it how you want. It doesn't matter. Friends, please, I ask you, if something is ununderstandable for you, just tell me, please. This is important because I don't need any mechanical words. If you don't understand, just tell me, I will explain it. But I think it's not so hard to imagine and to understand what I say. Let's continue, guys. I finished to draw the skeleton of our picture. Now, after you will meet three the same pictures, empty pictures without any vessels and nerves, of course without this aperture. You will just completely draw this skeleton. One for middle and one for lower third. But let's fool it now by the content, and let's start from subcutaneous fatty tissue. Now, in subcutaneous fatty tissue, approximately mid position, I will draw one big blue point. In my picture, it is the 7th one. And look here, please, by line, I will insert it into the space A. You can see this structure here, huge, big, blue tube. Vena saphena magna. We will see it up to your foot region. Yes. Vena saphena magna, look everybody to me, forms in the dorsal foot. In the dorsal foot region, we have the venous network. And from this venous network, biggest superficial vein is formed. By the way, it comes to the anterior margin of the medial malleolus. And from anterior margin of medial malleolus, we provided imaginary line up to the medial epicondyle. And from medial epicondyle up to, I told you before, midpoint of inguinal ligament. Here, it will become to here to saphenous and will be draining side. Why it's so important? Because if you will work in the sphere of the angiovascular surgery, you will very usually use these landmarks to make access to this vein. You can use this access for so-called phlebectomies in case of the varicose disease. Or you can use this access to take some natural processing material, to make, for example, different kinds of the shunting surgeries. Usually we take parva, but we can take and magna one. It is the auto-grafting material for different kinds of the surgical shunting, surgical perforation, vascular, mainly cardiovascular, but not only. So remember, please, you can make access to these veins, and you must know about it. Let's continue. It has the midpoint position here, In the same position, little bit laterally to it, I draw the big green point. I don't have yellow, nerves I will draw by the green. And that will be structure 8, call it please, nervus cutaneus femoralis anterior skin nerve of the thigh. I think the brackets right, it is from nervus femoralis, it is branch of the femoral nerve. Skin branch of the femoral nerve. Side, put the 9 point and call it nervus cutaneus femoralis lateralis. Last time we drew it inside the muscle. Again, it is lumbar plexus. Here, guys, remember, all anterior compartmental nerves will be from lumbar plexus. Posteriorly, you will see sacral branches. And in the medial side, guys, instead of 1 point, I draw 3 points. And altogether, I mention like the 10. 3 terminal branches. In the brackets, right, please, it is the ilia inguinalis, ilia hypogastrica, and ramus femoralis, and genitofemoral. This is prove you, guys, that the best sensory supplement in the thigh, inferior medius. This is the huge receptoral area, and that's why, by the way, the pain from this region is usually very intense in case of ruptures, traumatizations, and yes. One more green point I will put in the back side, 11.
Posterior.
Again, posterior skin nerve of the thigh. Remember, please, infrapiriformis aperture. And together with nervus ischioticus, it comes to out by this aperture. Then it is continuous to the posterior surface of the thigh and innervated. By the way, of course, from sacral plexus, because this is posterior. Yes. And look now to me, guys, in the level of these medial nerves, a little bit deep. Little bit deep, it means in deep layer of the subcutaneous fat. I draw 3 red points, and now it will be 12. This is exceptional structures, as you remember. structure is exceptional because normally in fatty tissue of
We don't have arteries.
we don't have arteries.
Arteries, yes.
We have only, that is exception. Call it, please. Superficialis, circumflexity superficialis, pudenta externa.
Externa.
And of course, guys, I can mention here, if we need it, yeah, that they come to out again by the hiatus saphenous and from the space A, because after in space A I will draw the femoral artery, and of course they originated from this space A, and then from space A come to the fatty tissue, and after leave the femoral region, come to the anterior abdominal wall, and here finally make the supplement of the structures. Is it understandable? Yeah, well, guys, let's make conclusion about fat. Because all necessary structure, except, by the way, two muscles I will draw in the fat, it's so-called superficial muscles. It is the sartorius, it is musculus tensor fasciculus, a little after I will draw it. But let's make conclusion. What can I say about fat tissue? First of all, it is great developed in femoral region. By the way, biggest development we will see in the medial cells. Medial fat is very good developed, but it's loose. It doesn't have the surface. Let's remember that inside of fat we have superficial fish. It is split fat into superficial
and deep.
And it gives the surface into the skin, except the medial surface. Here we don't have the developed surface. Keep it in your mind, remember about it. By the way, don't forget that inside of the subcutaneous fat we have superficial lymphatic system of the extreme. So we have two lymphatic systems, deep, which is located under the proper fascia, along the biggest veins, and superficial, along the biggest superficial veins inside of the subcutaneous fatty tissue. So extremities has two lymphatic systems, superficial and deep. Let's continue. Now, this is what I want to show about the fatty tissue. Just two, let's draw together. One I draw in the level of this tractus iliotibialis. And what is important, guys? Of course, this is number 13, yeah? Call it musculus tensor fasciculata. Only in upper third, yes. After it disappears, yeah? And what is important? Proper fascia cover it.
Fuse with it.
And forms the capsule. It's like, this is not like your impression on muscles, which is covered by superficial fascia. It is in the fat, but it is covered by the proper fascia, not by the superficial fascia. And one more ring, I will little bit move it, these structures into lateral side, because I need the trees here. And immediately laterally to our femoral triangle, I will draw here the sartorius muscle. It will be in our picture 14 structure. And again, I will cover it by the proper fascia. Again, I will cover it by the proper fascia. Okay? Sartorius, you know, it passes from up to down, from the lateral
to the medial,
superiorly infused with anterior spine, inferiorly it comes to medial epicondyle, and here together with several muscles it forms the pes ansarinus. Yeah, we will discuss it now. I think it's time to go deep, to go to the interfacial spaces. And first of all, in space B and in space C, draw the lines. It means fat.
Empty.
No vessels and no nerves. No vessels and no nerves. Let's come to the most important space for us, space C. And let's draw three structures. Look at this: blue, red, and green. And you can see that in frontal plane, being directed from medially to the lateral, located in frontal plane, guys. Okay? Let's give different numbers for each these structures. These are last nine numbers. 14, let's say this is 15,
16 and
16,
and 17.
and 17. Of Of course, you know that this is femoral neurovascular bundle. That's
Yes.
call it, please. Arteria femoralis, vena femoralis, nervus femoralis. Vice versa. Vena, artery, nerve. Yeah. From medial to lateral, VAN. So now what we achieve finally, guys? We achieve the interfacial space with the main neurovascular bundle of the lower extremity. Not only femoral region, but lower extremity. Yeah. For the 17, open the brackets and write please inside of space A, it's finally divided in branches and finish. In middle third, you will not find it. But you will find the longest branch of it, which is called nervus saphenous. And in middle third and in lower third, it will pass together with femoral vessels. Look, saphenous in Greek, it means superficial. But in middle and lower third of the thigh, it's not superficial, it is deep. But it doesn't have deep function. Yeah, it is transitory path, innervated anything, until reach the lower third of the thigh. Okay. And starting from lower third, it is passed to the fatty tissue.
Superficial.
And up to your foot region, it will innervate the medial surface of the skin. Okay?
Yes.
So remember it, please. And let's draw something more. Behind the artery 16 to the smaller point, it is point 18. And call it, please, deep femoral artery. Arteria profunda femoris. This is a single branch of the femoral artery inside of the triangle. It's located not below the big picture, but behind of artery. Yeah? For example, this is femoral artery, and it gives the posterior branch, which is called deep femoral artery. I think from anatomy you remember that deep femoral artery gives two branches. One which is surrounding femoral bone from medial side, and another which is surrounding femoral bone from lateral side. In our picture, let's put the number 19 and 20. Now this is the picture in frontal plane. Yeah, before we show sagittal picture, that is frontal picture. Call please 19 we call circumflexa femoralis medialis, and 21 we call circumflexa femoralis lateralis. As you remember, each of these circumflex arteries split it into two terminal branches, one to upwards, one to downwards. Ramus ascendens and ramus descendens. Ascending branches generally reach the gluteal region or pubic symphysis region, and here involves information of collateral networks of trochanter region, symphysis region. Descending branch in medial side come to the medial oscillatory compartment together with obturator artery. It supplies structures. Lateral is much more powerful and bigger, and it is reached the knee region. And this is one from 10 vessels, by the way, one from 2 descending vessels, which is much more important, which is involving information of the collateral network of the knee region. Ramus descendens, arteria circumflexa, femoralis lateralis. Remember, please, ramus descendens, arteria circumflexa, femoralis lateralis. By the way, finally, inside the inferior portion of the triangle, these deep arteries split it into 3 perforating branches. We call it prima, secunda, terza, first, second, third in Latin, yeah? And they perforated the septa from up to down. They come to the medial compartment. Then they perforated the septa C or B, I don't know which one is it.
C.
And finally they come to the posterior compartment, and they supply muscles, flexor muscles in the posterior compartment, perforating branches of arteria profunda femoris. But that is happened, of course, not in upper but in middle third. Yeah, this perforation, I think we understand. Yeah? Near the inferior border of upper third, they originated, that in middle third they perforated and reached the posterior compartment and supply the muscles in the posterior compartment. By the way, again, posterior compartment, you know, 3 muscles: biceps, semimembranosus, so each one will need one muscular supply. Do you have any question? If no, let's continue. Now let's become to osteophytes. And first of all, guys, in medial side, in lateral side, touch one muscle to the septa A from lateral and one muscle from the medial side. You know, I told you what is it. It is floor of your triangle. So let's put the numbers 21 and 22.
Iliopsoas and pectineus.
21 called iliopsoas, 22 called
Pectineus.
pectineus. And remember that it forms the floor for your femoral triangle. Floor for the femoral triangle. By the way, pectineus doesn't reach to this superficial layer of the proper tissue. Finish it approximately 2-3 centimeters below. That is important after you will see why. And let's continue now to draw the muscles. Here we have quadriceps, you know, yeah, it is the biggest extensor. That's a 1, 2, 3, and 4. And put the numbers 23, 24, 25, and 26. 23 it is rectus femoris, 24 vastus intermedius, 25 vastus medialis, and 26 vastus lateralis. Medialis, lateralis, intermedius, rectus. That is the most powerful extensor of your knee joint. By the way, it works also not only for knee joint, extension, but also flexion of your hip joint. So for hip joint, it is extensor, flexor muscle. For your knee joint, extensor. Your extensors for your hip joint, it is your gluteus maximus. Gluteus maximus. Okay, this is flexion. That is extension. Now let's come to the medial compartment. And why I leave this, please? Because here will be the next muscle. Next muscle, which is called 27, long adductor muscle. And if you will attract now your attention into these 2 muscles, 27 and 40, you will see that they border your femoral triangle from 2 sides. From laterally it is subductor, from medially it is the adductor longus. From upwards it is your inclinal ligament. Yeah, that's it. You can now recognize these structures. This is your long adductor, this is your sartorius, and that is your inclinal ligament. That is borders of the triangle. Okay? Let's continue. Next big muscle is bigger. Again, doesn't reach the superficial layer of proper tissue. It is 38. Call it please the big adductor, adductor magnus. 29, it is the short adductor, adductor brevis. And finally, superficially here, we have one more muscle, which is called the gracilis, muscle number 13. The grace muscle. It's located strongly for muscle in the medial surface of your thigh. The grace muscle. Okay?
Yes.
If it is understandable, let's go to the posterior compartment, divide it into 2 equal parts. Here, draw your biceps muscle, 31, 31, 1, 31, 2, short and long heads. Here also 2 medially smaller, 32 semimembranosus, which is much more superficial, and 33 semitendinosus, which is bigger and much more deeper. That's it. Between them, as you can see, also we have the groove. And don't forget that inside of the groove we will have biggest peripheral nerve, number 34, which is called nervus ischiaticus. And the more down you will go, guys, the more deeper inside of this posterior femoral groove, nervus ischiaticus will be inclinated. Remember its projection, by the way,
Midpoint of gluteal fold. Gluteal fold.
And upper angle of the fossa
poplitealis.
So this is strongly midline projectional line, which is connecting these structures to each other. Questions? So upper picture is completely finished. So now we will make the middle and lower cross sections. I think my time will be enough. Just 1 minute. I have 1 day already. And we will continue. Like any cubic, you draw please the second cross section. Absolutely. And I will now change here the structures, and then I will explain for you what is need to be changed. What is my last number? 34, yeah? 34. Don't speak, please. Don't draw any vessels and anything else. Empty picture. Wait until I will finish. Let's start.
Yes.
Inside of the head, draw again the same 7, 8, 9, and 11. No any difference to previous picture. But in the medial side, the new structure 36, and call it please ramus cutaneus nervi obturatoria, the skin branch of the obturator nerve, the 36 one. So you can see that the previous structures disappear, they finish in upper term. Instead of it, we have the new branch, which has come from the obturator. Draw, please, the sartorius exactly in the level of the medial interfacial space, just superficially to it. No any tensor fasciolata, you can see it is disappearing. The previous picture laterally, we have it now. Now go to the medial interfacial space, draw 3 structures. In our picture it is 35, 16, and 15. And you see, guys, they changed the position. In previous picture, they located in the frontal plate.
Yes.
Now they have sagittal position. That's what we have. Look everybody to me. 3 structures make, look everybody to me. This kind
will come from.
of course, instead of this, my finger, I have branch of it. Because nervus femoralis is finished. And we have the longest branch, 35. Let's say name, please. 35
Saphenous.
nervus saphenous.
Yes.
16 and 15 is same. Yeah, 16 it is artery, 15 it is vein,
Vein.
femoral, I mean. No deep artery here, because deep, as you know, I told you, yeah, to split it into perforating branches, goes to the posterior
Posterior.
compartment. Yeah. Again, in C and B, draw the line. There's empty spaces. Let's go to interfacial spaces. Space 1, everything same except iliopsoas. It's disappeared. Because we have it only in upper third.
Yes.
In the medial space, also same except pectineus. It's also disappeared. It is also located only in upper third. Posteriorly same, semitendinosus,
Same.
membranosus, little bit change position. That is not so critically important. Just draw the ischiadicus a little bit deeper inside of the groove, and nothing else. Nothing else. Hurry up, class time is very short.
20 minutes.
Now open the brackets and write please space A in middle third. We call anterior femoral groove. Sulcus femoralis anterior. Borders you see, yeah, from medial side it is the long adductor, from the lateral side it is the vastus medialis. Everything is visible. And about position of the elements also we mentioned from in front. By the way, nervus saphenous located not only in front but a little bit laterally, superficially in front is a little bit laterally to the artery.
Yes.
To the side. Yeah, I don't draw it in the picture, but it's located a little bit laterally to the artery. Now, guys, make the new picture, call it the lower third, again empty, until I will make some improvements in this picture. Don't speak, please. Let's start. Let's start again from the fatty tissue. Draw the 7 little bit shifted to the medial side. Again the 8, again the 9, again the 11. instead of the previously drawn here 34, or I don't know which one, draw 35 saphenous. But saphenous draw in two places together. And inside of the space A, and draw here again aperture in the roof of the space A. And through this aperture, leave it and direct it into the fatty tissue. So once draw it inside of space A, then draw it inside of the fatty tissue. Also in fatty tissue here, draw the new red structure, 38. Again, twice draw it. And inside of the channel, and inside of the space. This is new structure, you don't have name of it, let's call it please, after again this sentence. In the brackets write that this is branch of the femoral artery, after again this sentence. And of course the musculus sartorius, you can see that it is moved much more medially, yeah? That's because it goes from up to down, from lateral to medial. In each next picture, it's created a little bit more medially. Okay, in the fatty tissue, nothing more. Now let's go to the proper fascia. Again, space B, space C is empty. Come to the space A. Again, draw these three structures, 35, 16, and 15. Again, in same position, nerve is in front laterally, artery deep to it, deep to artery, we have B. This is syncope of the elements. Now, roof of this space A make very thick and with aperture, as I told you before. This thick roof, put number 39 and call it membrana vasta adductoria. And for this aperture, please, again, put the number 37 and call it anterior exit of the adductor's canal. Anterior exit of adductor's canal. In this level, this is enough. Little after I will give you all necessary information. Now let's come to the space, the same quadriceps here. Here, guys, something is changed. First of all, short adductor is disappeared. It is finished in the middle half. And two muscles change the position. One is go more medially, second goes more laterally or superficially deep, call how you want. Magnus come to the septa, longus goes a little bit far from the
posterior
septa.
side.
Yes, so they change the position. Again, the gracilis, number 30, no any difference. And posteriorly same, 31, 32, 33, and 34. New, absolutely same to previous year picture. No any difference. And let's now discuss last what I want to introduce you now. Draw it and look in the picture. Now attract your attention to this picture. That is space A in the left. Let's open the brackets and write please. Space A in this picture is called Hunter's canal or adductor, you remember, or femora popliteal, which name you want. Yeah, always correct. Now look, this canal has walls and apertures. By the way, three apertures. One is exit and one entrance and two exits. I make mistake. Let's say that is not the entrance, but it is exit. Please improve it. 30, I don't know which number. Anterior exit, not anterior entrance.
37.
You write exit? I'm sorry. There's a minute attention to me, guys. How this canal is formed? By the muscles, which you see, yeah? In medial side we have laterally vastus medialis, medially we have adductor magnus.
Yes.
As you can see, yeah? And anteriorly we have membrana vasta adductoria, structure number 39, which is why vasta adductor, because one side, what is it? Superficial layer of the proper fascia, which is come to the tendon shape form. It stands thicker because it fused with the muscles. laterally to the vastus medialis, medially to the adductor magnus, and it make this junction make this superficial layer very thick.
Yes.
If you look in this picture, it has untransparent, very thick form, yeah? And we call it membrana vasta adductoria. Remember it. Now, 3 rings of this canal. Upper one we call entrance and 2 exits. By the way, you see only 1 exit, which we call it is structure 37, which I drew in.
Yes.
About entrance of the channel, guys. Entrance forms in uppermost channel, and still instead of the magnus we have longus muscle. Let's say entrance is formed between vastus medialis and adductor longus. Then they change the position. And the wall of the channel forms not by the long, but by magnus. Anterior exit, it is aperture in the membrana vasta adductoria. You can see it. Just and through this aperture, 2 structures come to outside. First of all, it is the nervus saphenous. You remember I told you that it will come to the fatty tissue only in the lower third. After, will pass, by the way, together with vena saphena magna. And will make the innervation of the medial surface of your leg up to the foot region, dorsal foot region. And one more artery I draw, guys. Again, exception. Arteria 38, which we call genodescendens, come to the fat and after immediately again perforated proper fascia, and come to the knee region and locate it under the proper fascia. Yeah, that's it doesn't supply anything in the fatty tissue. It leaves the channel, come to the fat, then again perforated the proper fascia, goes to the knee region. Remember, please, collateral network of the knee region totally located under the proper fascia.
Yes.
It is not superficial structure. It is deep structure. Okay. And finally, we have the last aperture. It is the inferior exit of the channel. It is between the heads of the magnus, adductor magnus, and by this aperture, your adductor's channel connected with fossa poplitea.
Yes.
Near the medial epicondyle, we have this splitting of the tendon of adductor magnus into 2 legs, and between these 2 legs, arteria vena femoralis goes to down, come to the popliteal region, and rename here, and call here popliteal vessels. So remember, please, the channel has 3 walls and has 3 apertures. 1 it is entrance, and 2 is
Exits.
That's all, guys. This is what I want to give you. Today, I think it's enough because 3 minutes or 4 minutes I have up to finish of my class. Of course, it will not be enough to start the new region explanation. Do you have any questions?